So this is mainly Johnny's talk today, but I was just going to introduce a little bit at the beginning. So thanks ever so much for inviting us to talk about what we're doing. We're really hoping that you'll have some insight to help us as much as we're sharing what we've been doing, really. So this is some work. We're both from the University of Leicester, but I'm from the TIMS group who look at pregnancy and neonatal care and child health. And I work on a project called Embrace UK, where we collect all of the information across the UK on stillbirths and neonatal deaths. And through doing that and on a global scale, collecting information on stillbirth and death early after birth, we've really seen improvements in looking at what the burden of perinatal loss is across different countries, and also being able to start making more of a move towards identifying improved interventions, how we would sort of assess quality of care, how we make improvements to care to really help reduce rates of stillbirth and perinatal loss and improve outcomes for families that are experiencing loss. And what we really noticed was that actually the second trimester pregnancy loss, so loss before 24 weeks of pregnancy, where if you experience loss at this time, there's no registration of your baby's death. We don't have any idea of the numbers of parents who are experiencing loss before 24 weeks in the UK. And when we don't count these sort of losses, we don't have the ability then to make changes to practice and really understand the factors that are affecting loss rates in the UK and what we can do about them. So this project was really an opportunity to try and, for the first time, get some rates of the number of second trimester pregnancy losses in the UK to then take things forward to try and make some changes in provision of care, because we know it's very inequitable whether people receive care in gynecology or in maternity, and there's a lot of areas we could really look at improving, but before we have numbers, it's really hard to take that forward. So this is some work using the CPRD Pregnancy Register, which John has really been focusing on to try and get a first handle of that and take it forward. So thanks, Johnny.
Perfect. Thanks, Lucy. Yeah, so I've been working with Lucy for sort of about the last 18 months on this project, and I'm going to kind of give an overview of a little bit of the background that Lucy's mostly covered, and then what we've been doing so far and how we've been evaluating the pregnancy register and linking it in with other hospital records to try and routinely estimate these losses. So, as Lucy said, we collect this really good, reliable data on stillbirths via the Embrace UK audit, but we don't have this mandatory data collection. And I guess there's a lot of different reasons for this. One of the big ones is how much harder it is to collect routine miscarriage data, because miscarriages and early pregnancy losses occur in so many different settings. So across gynecology and maternity, early pregnancy units could occur at home. And they often, of course not always, but often occur without a hospital stay. So as a result, lots of these may go completely unreported to healthcare services, or perhaps might only be reported historically at subsequent hospital or healthcare visits, either in subsequent pregnancies or for separate reasons. But we know that there's this big burden on parents with that experience second trimester pregnancy loss, both psychologically and socially, in a similar way to stillbirth. And because we've seen how much improved the care can get as a result of routine stillbirth data collection in terms of the overall burden and specific risk factors, we thought it'd be really useful to be able to do this for second trimester and for earlier pregnancy losses, but we're sort of 10 or 20 years behind that at the moment. And this isn't just a problem in the UK, this is worldwide. No countries are really reporting on these losses. So our aim is to estimate these rates of what we're calling miscarriages. Of course, there are earlier trimester losses than the second, but we're kind of focusing on the second trimester loss because it's, I guess, even trickier to find any data on first trimester losses. And we're estimating these in the UK, hopefully by linking general practice data in with hospital episode statistics. So we're using the clinical practice research database Pregnancy Register and focusing on the period from 2000 to 2020 with the hope that this gives us a kind of a wide range of hopefully good quality data and allow us to investigate changes in time and also give some fairly up-to-date estimates, hopefully. And this is kind of key if we're going to be able to develop policy and practice in this area. We need to know what the burden is and which groups are at risk, such as kind of socioeconomic or ethnic risk factors, which we know are present in stillbirths. So just in case anyone isn't familiar with what the CPRD is, although I'm sure most of us are, it's an electronic health record with primary and secondary care records. It's available from consenting UK-based general practices. It was first called the GPRD, it's now called CPRD for clinical instead of general. So it's kind of expanded over time to include linkage to more and more databases. So things like hospital records is really useful to link in hospital visits, disease-specific registries, so cancer registries or other disease-specific ones, and ONS mortality data. So if you want to increase the accuracy of the mortality data that you have with the CPRD, then ONS mortality linkage is quite standard. It comes as in CPRD Gold and Aurum. This kind of just based on the software that the general practices are using to store the patient records. And there's no sort of systematic difference between the two. Gold was established first, but over time, more and more databases are transferring over to Aurum. Perhaps less of you might be familiar with what the CPRD Pregnancy Register is. So this is one of the kind of derived databases that you can get from CPRD. So it takes records from both Gold and Aurum, and it applies this algorithm to try and identify anything that it thinks could be a potential pregnancy. So it looks at medical codes, it looks at product codes, it tries to find kind of anything pregnancy related, so antenatal visits, deliveries, miscarriages, outcome data on live births or stillbirths. And it will kind of try and group these up into what it thinks are plausible individual pregnancies. And then based on those groupings, estimate where the start and end date is. And it typically kind of will end up with an end date and then backdate to see if it can find any other earlier information to estimate a start date from using gestational age or if it doesn't have that kind of guesswork from the outcome data. So it can capture pregnancies both with and without explicitly recorded outcomes. So obviously the data that have more explicit outcomes in terms of the data that's available will be more reliable, but it will sometimes kind of find something that seems to correspond to a pregnancy that kind of stands alone and doesn't seem to be linked to any other pregnancy in the pregnancy register or in that patient's CPRD records. And then it will kind of say, this is a potential pregnancy, but we don't know what the outcome is. So it keeps that as an unknown outcome. So as a result, there's some uncertain pregnancy episodes in there as well. And I think that was one of the first big lessons that we found while using this was perhaps going into it, we were expecting this to be a definitive list of all of the CPRD observed pregnancies that occurred in the UK from 2000 to 2020, and that would then be quite ready to go and analyse. But in fact, it's important to understand that this is kind of pulling together as many potential pregnancies, and it needs validation, or at least a careful consideration of which records you're going to use for your analysis and which ones you think might not be relevant or sufficient quality to include. So documentation that you get makes it look kind of quite clean and nice. It's very well cleaned before it arrives. So you have a patient identifier and a pregnancy identifier for the episode within the mother. Then there's a few other kind of useful variables that come with the pregnancy register. So there's a start date and an end date. There's the estimated kind of second and third trimester dates that are calculated from that, assuming the pregnancy goes to those dates. Some other really useful ones in terms of what we've been looking at are the start source variable, which I'll come back to later, but it's basically on denoting how it estimated the start date. The estimated duration of pregnancy in days, which for our work where we're looking at temporal loss over the period of gestation is really important. And the outcome variable, I guess, is a really important one to us for what it estimates the outcome to be, or if it says that it doesn't have sufficient data to estimate or know an outcome. So this outcome variable has got 13 levels. So there's live births, stillbirths, miscarriages. There's a few other earlier outcomes. There's a few outcomes that are quite confusing to get your head around. So there's documents outcome 3 as a live stillbirth, which I think is a little bit of an oxymoron perhaps, but we've been assuming that those generally correspond to stillbirths. There is a very small percentage of those. I guess perhaps there's conflicting records in those patient records that might suggest why it's being stored as 1 and 2. And then there's some unspecified losses where it believes that the pregnancy was it did end in a loss, but it doesn't know why or how it ended in a loss. And then there's the outcome level 13 is if it's an unknown outcome. And there were quite a lot of records in the register extract that we had that ended in an unknown. About a quarter of the records, it said it didn't know what the outcome was. So we first kind of looked at the number of live births by year. So this is a plot across Orham and Gold of the number of live births that each the total number of women in each year was observed, and we found that there was a decreasing number in both Gold and Orham, which was initially a bit concerning to us because we thought that the kind of pregnancy number of pregnancies over time has been kind of steadily increasing. But then we spoke to an expert and found that actually this was what they expected to find too, and this has been previously published. And one of the reasons for this is that even though the patient numbers in CPRD Gold and particularly Orham have increased in this time period, there's been a change in how pregnancy care is managed in the UK. So since 2007, then pregnant women have had the option to register with a midwife directly rather than attending their GP practice first to confirm their pregnancy. And a report in 2019 found that about half of women in the UK were accessing their maternity services in this way. So essentially, while we were initially concerned, this was to be expected, but it's worth bearing in mind that our patient number is decreasing over time. We then looked at the gestational lengths, and this was including all of the different outcomes, and we found these 3 really big peaks. So there was a high peak at 4 weeks, at 12 weeks, and at 40 weeks. And while we might expect a kind of an increase in the number of pregnancies at 40 weeks, this seems an artificially high peak, and we certainly wouldn't have expected this many pregnancies to end at 4 and 12 weeks, especially when there were so few either side as well. And we kind of when we looked into the outcome of these, we found that this was highly linked with how the algorithm had estimated the start date. So the 4 weekers correspond to unknown outcomes, the 12-week peaks corresponds to miscarriages, and the 40 weeks correspond to live births where there wasn't any more data to estimate a gestation. So this comes back to the start source variable. If there was more if there were more records that the algorithm could use to estimate the start date, so numbers 2 to 6 onwards, then that indicated a higher level of accuracy with the pregnancy start dates. But the level 1 being imputed indicated quite poor level of data quality in terms of the start date, where it would just say here's an outcome at 40 weeks. We know it's a live birth, but we don't know any more than that. We'll assume it occurred at exactly 40 weeks. So they have the date that it occurred on, but not anything more than that. And similarly for the 12-week losses, they know that a miscarriage was reported on this date. So they just estimate the start date of that miscarriage to be 12 weeks earlier. And there's a lot of records that have this kind of imputation of the start date occurring. So when we took those records to one side and just looked at those that didn't have an imputed start date or an unknown outcome, we found a much more plausible spread of the data across gestation. So kind of a smoother increase in the estimated rates of loss at earlier trimester, and then rates of live and stillbirths as pregnancy gestation increases. So then we thought perhaps we should just focus on these records that have more plausible outcomes more plausible start dates. So the pregnancy register extract that we had a 12.8 million records in approximately, and 2.5 million of these had non-imputed records with a known outcome. So we were dropping a lot of potential pregnancies by doing this, but we thought that at least we would have a much more plausible cohort to estimate the losses from, and that, yeah, within that we'd get reliable estimates, even if it wasn't fully representative of all of the records in the pregnancy register. It would at least be more reliable in terms of the start date and therefore the gestation. But when we focused on our analysis on these non-imputed records only and compared them to the embrace rates of stillbirth, we did find that across stillbirth there was relatively good agreement. So from 24 weeks onwards, slight underreporting of losses in CPRD compared to the embrace audit, but quite close. But we found that there were a lot higher rates of loss at 22 weeks and 23 weeks, and as a result we think that our estimates in earlier gestation might also be too high, which perhaps could be because we have too many miscarriages that are being included, or too many earlier trimester losses that are being included, or potentially not enough stillbirths and live births that are being included when we exclude all of these non-imputed records. So the next suggestion we had, which is kind of what we're focusing our analysis on now, is to look at the HES records, because we have HES records for all of the mothers in our extract. And within that, we can look at diagnosis files for ICD-10 codes corresponding to outcome of delivery, which are Z37 codes, or what's called the spontaneous abortion, which includes miscarriages, which are the 003 ICD-10 codes. So the Z37 has different levels denoting whether the outcome was a live birth or a stillbirth, or if it was multiple births, then if they were all or one or no live births in the pregnancy record. And if it's uncertain what the outcome was, then it is stored as Z37.9. And we have similar records for the miscarriage ICD-10 codes in 003. So we thought that we could perhaps focus on the records that we don't have the known start date for, and see if we can link these to some HES records and improve the quality of these records, or perhaps identify a more plausible start date or a more plausible outcome for those records, and so increase our patient numbers and perhaps result in some more plausible estimates. So yeah, we had quite a few Z37 outcome records for the mothers in our extract. So most of them corresponded to live births for the Z37 records, and we had a few spontaneous abortion, including miscarriage codes as well, but far fewer than the Z37 data. And these records, particularly the Z37 records, can be linked to gestational age as well in HES. So our thinking was to compare those to the records that we don't have a known start date for. And so either we can use the known start date for those records that we have a gestational age for, or we can kind of go back a plausible amount of time, which I'll show on the next slide, where we've chosen to be 40 weeks for a live birth outcome or a stillbirth outcome, which is the Z37, and 24 weeks back for an 003, and see if there are any records that we can pair up. So perhaps that'll make some more sense when I show you these examples. So we're looking to essentially validate the non-imputed, the imputed start dates and the unknown outcomes with our HES records to then include with our more reliable non-imputed start dates. So here's like a hypothetical example in example 1, where we have, say, a mother has a pregnancy loss recorded on the 1st of January 2005, and then they go on to have recorded another pregnancy loss, both of which are imputed. So dashed lines here are indicated an imputed record. And the yellow line indicates that we might have a HES loss observed for that record. So in this case, we'd perhaps ignore or not include the first pregnancy loss for this mother, but then include the second loss because it has a HES record that matches to it. And similarly, we have then a live birth for her fourth record, which matches up with a HES live birth. So again, we'd include that in our analysis. Sometimes it's a bit more complicated than that. So in the second example, we have a mother with two overlapping unknown outcomes alongside an overlapping live birth. So we'd then go into the HES records and see if there were any records there that might give more weight to one of those records than the other. And in this case, we might look and see that they have a couple of HES live birth outcomes recorded at a similar time to the CPRD live birth. And so we'd say that we trust the live birth record more than those unknown outcomes and remove the unknown outcomes for analysis, but include the live birth as an outcome. So that's the general idea, but unfortunately it's often a lot more complicated with some of the examples that we have where we have much more overlapping. So this is a record that we do have, but that's been obviously anonymized, where the mother has lots of overlapping live births and losses and some conflicting HES records too. So we need to come up with a sensible way of deciding which ones we think can be kind of disentangled into a plausible record, or which ones just conflict too much and we can't take any of those records forward. But as I said before, this was our kind of current analysis where we had focused on the non-imputed records of 2.5 million. But we're hoping that because we've got so many with imputed start dates or unknown outcomes, if we can link these in with the HES 003 and HES Z37 records, we can perhaps increase the number of records that we can include as more reliable in terms of their outcome and their gestation. Then that's only going to improve our analysis. So the hope, once we've done that, is to then kind of come up with a final cohort where we remove any overlapping pregnancy records, which perhaps can be done as part of this validation process. So we initially defined a set of rules when we were focusing only on the non-imputed records because there were some overlaps within those. So we're potentially going to revisit those and apply those to our final cohort, and we'd probably prioritize the non-imputed records or records with known outcomes over ones that we've kind of gone into the HES records for to try and improve. Similarly, there's probably more biologically plausible records we could take. So a live birth recorded before 22 weeks, which we do have a few of, is probably less plausible than a loss recorded at this time or a live birth recorded at a later gestation. And again, if the records are too conflicting, then we may have to decide that neither of those can be included in our final analysis. And so then the goal of that is to have kind of this final non-conflicting, reliable cohort of mothers and of CPRD records to include in our final analysis, from which we'll be able to estimate crude rates of pregnancy loss across the second and validate with estimates in the third trimester. So yeah, the second trimester rates are what's really of interest to us, but the third trimester rates can be compared with Embrace for validation. And we can also pull in a lot of secondary analysis in terms of the demographic factors we'd like to look at. So maternal age was available within the pregnancy register. We can define a birth cohort to investigate changes over time and pull in hospital records to look at the birth number, the maternal ethnicity, the socioeconomic status, and see if there's any variability in rates by these factors. So that's kind of been a whistle-stop tour of some of our struggles in working out which records we can and can't include, but the goal of which is to get these robust estimates while, of course, acknowledging the limitations. And our hope by doing this is that because this is routinely collected data, if we can derive a robust cohort now, then we also set up the ability to routinely collect this data and routinely estimate, and that would allow us to evaluate whether or not improvements are being made over time or identify subsequent risk factors that might emerge. So we kind of recognise that this has been a balance between needing our estimates to quantify the burden, but addressing the quality of the available data. So we had a kind of a sticking point where we were debating whether or not to proceed solely with our non-imputed records because we felt like that data was better than no data, but then felt like we were ignoring a lot of potential pregnancies that needed the quality improving to include in our analysis, but that would of course then take more time to do so. So we would really appreciate kind of any thoughts on any of this, on striking that balance, or perhaps any thoughts anyone might have on how to combine and match up those CPRD and HES records, and how you would come up with rules for deciding which ones to include or not. Or if there was anything else in this talk that you thought would be interesting, or you have any questions on, we'd really like to hear. So we're happy to take any questions now, or do send me or Lucy an email. I've got my email there on screen if anyone would like to do so. And just lastly, thanks to everyone that's commented and given their suggestions so far, because we've needed a lot of support in varying ways throughout this project. So thanks.